Hello and welcome to the Longev Lens. Please join my co-host, Dr. Sebastian Pedersen and I as we cut through the noise and hype around longevity, health and wellness and turn the latest evidence into honest, practical insight for living better for longer.
And just a quick disclaimer before we dive in, this podcast is for educational purposes only and doesn't constitute medical advice. If you have a healthcare problem, please consult your doctor or qualified healthcare professional.
Welcome back to the Longev Lens, where we cut through the noise and hype that comes back from the health and longevity space, and we try to give you the best evidence-based information that we possibly can. Today we're joined by, again, Dr. Seb, and very luckily we have Professor Belinda Beck with us, who is world-renowned in the bone health space and has pretty much helped to change how we now treat bone health, and has published over 150 scientific papers, which is an incredible feat. So we feel very fortunate that we actually get to have you today. For anyone that doesn't know, what is your background and how have you got to where you are today?
Well, probably started way back when I was an athlete and used to suffer from sore shins, and that's what started me being interested in bone. So as a master's student, I studied bone stress injuries, tibial stress injuries. And then as I sort of progressed into my PhD, it was very obvious that this was a bone injury, not a muscle injury, but everybody else thought it was. And that got me hooked on bone because, and I'll argue this with anybody, bone is the most fascinating tissue in the body. It's the most amazing. It's wonderful when it breaks. It heals with new tissue, not scar tissue. It responds to loading. It interacts with all the other tissues in the body. So, yeah, I was hooked. I did animal work as a PhD project, but as an animal lover, I knew that I couldn't last in that for the rest of my career. So I moved into human research and went to Stanford for my postdoc and learned how to do clinical trials, and then came back to Australia and picked up my position at Griffith University and have been teaching anatomy and doing bone research there ever since.
Yeah, where I first met you, Griffith Uni.
Yeah,
so, yeah,
I know.
takes me back to the heyday.
Undergraduate too. All starts at Griffith.
Oh, really?
That's right.
Yeah.
It's great.
Yeah. So what was your PhD?
Well, it was a PhD in exercise physiology, but it was actually looking at streaming potentials in bone, which are sort of electrophysiological phenomena. When you bend a bone and the bone fluid moves, you can measure the change in polarity, essentially.
Yeah.
So I was looking at turkey bones in a really cool turkey model that was developed by Lanyon and Rubin. And I was working in Rubin's lab. And we were just looking at whether you could determine where bone adapted from the polarity on the bone, if you like.
Yeah, okay. And so you said your passion from bone health essentially came from your own experience as well. As obviously at a younger age, this has now developed over the years because a lot of your scientific papers have been published in postmenopausal women, osteoporosis in men and in women as well. How has that changed and developed over the years as you've gone through? Yeah,
look, it's interesting, and I've maintained my interest in bone stress injuries throughout my career, so I've got this underlying other program of research in bone stress injuries in the military and in athletes and so on. When I first came to Griffith, and I was starting to sort of dabble in the area of exercise loading for bone, I was aware that the population that had been the least studied was adolescents. There'd been quite a lot in prepubertal children, quite a lot in older adults, but we were beginning to realise that the window of opportunity for growing bone was during adolescence because, as you would know, by the end of the second decade, you have all the bone almost all the bone you're ever going to have. And so the opportunity to increase your bone bank as much as possible, that window of opportunity was closing. So I thought, why don't we develop a program that maximises bone development, maximises peak bone mass so that people start with the maximum amount of bone that they can have, and across life, if they do lose, then maybe they end up with a higher place to start from. So that was the Power PE study. We did that in Year 9 kids in a local high school, and we found that because you don't have to stimulate bone very much to get a response. So we did a 10-minute jumping intervention at the start of every PE lesson and showed that the kids that were randomised to the jumping group did actually improve their bone. And interestingly, the boys in that study lost fat.
Okay.
And so there was this benefit to body comp. And then we measured them years later, right as they were about to leave school in Year 12, to see if they'd maintained the benefits, and they had. So
really?
this was very cool. We then did one other study. A student came to me from Brazil who had worked with kids and body comp, and I said, well, I'm sort of interested in body comp, but not really. I'm more interested in bone. So we did the Capo Kids trial, also in schools, and I'm not sure if you're familiar with capoeira, because the idea, if you're trying to make kids grow bone, you have to do something that's fun. Otherwise, it's not going to work.
Kind of thing, isn't it?
This cool little dance program, and we added in some impact exercise, which we know you know for bone you need. And so again, these kids came out 10 minutes a day before. The Year 5 kids came out before lunch, the other ones came out after lunch, and again, we had these wonderful benefits. And not only did we get these benefits in bone, but the teachers told us they were so much more settled in class and their focus. So it's the same old story with exercise. It's just there's no downside. And the spin-off, so you might be focusing on one tissue, but everything benefits.
Yeah, correct. As you say, it's not just bone, it's tendon, it's muscle, it's the hormones, it's brain health, it's absolutely everything, body composition, as you say as well.
Yeah.
So again, just to wrap up, I guess part of the passions as well. Why should people really be focusing on bone health? What is in your passion that you'd like to see people focusing on their bone health?
Well, I think bone is largely ignored because it's invisible. It's just that thing that's there that supports us and our muscles attached to so that we can move, protects our brain and so on, all those basic functions that we think of as bone. And most people think of it as largely inert. But the fact is, it is so incredibly important at the end of life, because if it is so weak that your propensity to fracture is high, then it absolutely makes your world collapse in on itself. If you have a fracture, particularly if you have a dramatic one like a hip fracture, your mobility is affected, and oftentimes if you're quite old, it sends you into a nursing home where you weren't necessarily headed because you were living independently. And in fact, if you're 90 years old, most 90-year-olds who have a hip fracture are dead within 6 months. And so this is a quality of life thing. This is not just the pain and suffering and cost, financial cost of the event. It's the sequelae of what happens after your fracture. And like hip fractures are the big one, but vertebral fractures, when they happen, not only are they painful, but if you have a crush fracture from a vertebral fracture, it makes you shorter. So immediately you can't reach half the things in the kitchen that you used to be able to reach. It also makes you less mobile, so it makes you stiffer in your back, so you can't move as well. Can't look over your shoulder when you're driving your car. If you have a wedge fracture, it gives you that curvature of the spine, which we refer to as the dowager's hump. And only that can happen, of course, in men and women. And that, of course, creates this deformity where suddenly your vision is angled towards the ground more, and that also slightly changes your centre of mass. So straight away your risk of falling is greater. So that means that your risk of hip fracture is greater because you're more likely to fall. So it's this sort of snowballing of downward spiralling, and we just feel like if we can arrest that, people can stay like us, walking upright, strong, independently living, and getting the most out of life throughout their life for as long as possible. Definitely talking about health span here, and just I think everybody would agree you want to be as independent with as high a quality life as you possibly can.
Yeah, that's really part of our
that's exactly
as Longev is what are we going to be looking like when we're
100%.
85?
That's exactly right. And I mean, even in the hospitals when I was there a couple of years ago, the epidemic of osteoporosis is just phenomenal.
Mm-hmm.
I still think it's significantly under-recognised because, for one, you say, and I agree with you, it's a silent disease. You can't see it on someone. What would you like to see over the next decade or two that changes how we approach bone health, both as a public awareness campaign, but also individuals?
Yeah, look, that's the million-dollar question, isn't it? Because it has been a really intractable problem. But honestly, I think it starts in med school. If the doctors are more aware of it and more aware of what needs to be done to diagnose it early and prevent it happening, it could be cut off at the pass. Now, my daughter is in year 4 of med school. Do you think she's had one? I reckon she's had maybe one class on osteoporosis. The number of classes she's had on exercise, I don't think even registers.
We don't get any. And then the class on osteoporosis would be medications to use for osteoporosis, not actually preventing it in the first place.
Right. And I'm currently watching the series Dope Sick, and there is a lot that rings true with pharmaceuticals and bone medication. Now, I'm certainly not maligning them all at all, and they're necessary.
Absolutely.
But pharmaceutical companies driving education is not the way to go. You know, it should come from science and medicine.
Yep, I couldn't agree more.
Who do you find is most at risk as we start to age and develop? Because we're finding now that we're testing a lot more patients as well, males in particular in their 50s, finding a lot more males who are having osteopenia than what we would have expected.
Yeah. Well, it's still a largely female condition because we get less bone at peak bone mass and we lose more across life because of the rapid loss around menopause. So there are still more women with very low bone mass, and also they're more likely to fall at the end of life. However, that preponderance of the burden in women has blinded the medical community to the fact that men are at risk. And it is a genetic condition. So to
pull you up on that, I've read different studies, 50 to 85% of bone health is determined by genetics.
Yeah.
Where in that range do you sit? Is sort of 50-50 between lifestyle and genetics, or mostly due to genetics itself?
I'm up in the 70% genetics, for sure. I mean, in the same way that you can tell the athlete who's going to have the bone stress injury just by looking at them, you can tell who's going to have osteoporosis just by looking at them. It's the small-framed person, typically short stature, but not always. It's the very low muscle. There are a number of other things that I probably wouldn't, they're just anecdotal and there's no evidence, but certainly we know that low body weight, light, short, white females, that's your classic osteoporotic person. And yet, if you come to the clinic, you will see every single different kind of person, including men. But if we're talking numbers, I would say there's probably 6% of the patients at the clinic are men. That's partly because of prevalence, but partly because of lack of diagnosis. And you guys don't go to the doctor.
No,
I was just about to say that.
And if you did go to the doctor wouldn't test you for osteoporosis because you're a guy.
Exactly.
I asked my dad that the other day. I know my mum's had bone mineral density scans, like DEXA scans, for the last 10 years at least, but
And
my
I bet
dad
he
never had
hasn't.
one. He's almost 70, so that's his next on the list.
So easy to do.
Yeah.
Like lie on a soft mattress, 5 to 7 minutes, very low radiation, super cheap.
Super cheap.
And even, like, do you ever use CT or ultrasound to diagnose osteoporosis? Because obviously you can diagnose it radiologically, DEXA scan being the most common, or clinically, which is often what you see in hospitals. People come in with a fracture because they've never had any scans before. Is CT or ultrasound something you ever use in any of your studies or population groups?
I don't use CT, even though the radiation has come down. It's still sort of higher. It doesn't have the same reference database so that you can plot people and give them a T-score, which is what how you There are quite a few different ways that you can image bone, as you would know, and there are a few new ones, including a new ultrasound technique. They're early days. That's a whole rabbit hole we could go down. Quite controversial. The argument is that DEXA is not perfect, and I would be the first person to say it's not perfect. There's a number of reasons why it can be misleading. So if you have coexisting arthritis in your spine and low BMD, the arthritis will artificially inflate your BMD because it's this dense little blob of bone in there that is not actually part of your bone. It's an outgrowth.
Yeah, okay.
And so it doesn't give it the structure and integrity that like a real bone.
That's
would be able
right.
to
It's
show?
called
Okay.
an osteophyte. So it's an outgrowth from the joint line. It's not part of the bone itself. It's a joint problem, not a bone structure. So the bone itself could be very, very weak. And yet you get this high T-score, and so you have this sense of, well, my bones are fine, and actually they're not. It's why the original WHO definition of osteoporosis with the T-score was at the hip, because you don't have the same problem there. But the problem at the hip is if you don't get your positioning right, it can also affect the outcome. So there's a million bad things you can say about DEXA. However, whereas maybe 10, 15 years ago I was very anti-DEXA, I have come full circle. I wasn't very anti, but it wasn't my favourite measure. I've come full circle to recognising, as you say, it's quick, it's cheap, doctors know how to interpret it, you get a T-score very easily, and by and large it is the best indicator of how low your bone is. On a population scale, it has been extremely beneficial for us being able to know somebody's risk and when they need therapy.
Yeah, no, I agree. And just for the listeners out there, if you get a bone density scan, it will spit out two numbers. One is a T-score and one is a Z-score. T-score being where you're compared to young, healthy bone health or young, healthy individuals, sex matched as well. And then it ranks you based on statistics, so standard deviations. Between or anything above minus 1.0 is referred to as healthy or normal bone, and then minus 1.0 to minus 2.5 being osteopenic, and then minus 2.5 and below being osteoporosis.
Yeah.
And then you have the Z score, which is for people who are, the T score is used for ideally postmenopausal women or males over the age of 50. And then you have the Z score, which is age, sex matched, and can even match ethnicity as well, which is used if you're a male under the age of 50 or if you're a premenopausal a woman. Just to give you an idea of which Z score, T score you use depends on what age you are and also what sex you are.
One of the really important things about T-scores is that they can be a little misleading as to risk. We know that if you have osteoporosis, you are at the highest risk. If you have minus 2.5 T-score, you're at the highest risk because your bones are weaker, so there's less bone there, structural support. However, because if you think of the bell curve distribution of T-scores across the population, most people are actually going to be osteopenic in postmenopausal years, not osteoporosis. And that actually means that most people who fracture are actually osteopenic, not osteoporotic.
Correct.
So it's really important if you find out you have osteopenia to not go, oh, I'm fine, I don't have osteoporosis. Actually, you are still at risk and you still need to do something about it.
Oh, 100%. And not only the T-score, but the Z-score as well. Like exactly as you said earlier, if I take a history from someone and I'm looking back into their life, if they've never played sport, they were very sedentary, their parents never did any sport either, and they have a family history of fractures, then for me, having a Z-score that's close, it might even be 0.9 or 0.8, but knowing that they're already now in their 20s, 30s, well below average, then it's okay, now it's time to act. We need to do something, otherwise we're going to run into problems.
Absolutely. And we did actually do the Optima X clinical trial in women with low bone mass
Yep,
between 18 and 30 to try and see if we could actually put a few more rungs on the board before they reach peak bone mass. Unfortunately, had a lot of trouble recruiting that age group. Very, very difficult age group to get to come twice a week to an intervention because they're just busy. They're students. They're, getting their careers up and running. So it was a difficult study to run.
I could imagine.
Yeah, you said earlier as well, peak bone mass happens in the second decade, which is that related back to height? So again, being that's a bit more of a genetic thing, does that have anything to do with the density of the bone?
Yeah, both. So we know we're not like crocodiles. We don't keep growing our entire life. Our growth plates do fuse, and for women that happens roughly by the time they're 18, and for men round about 25. So actually the mean age of peak bone mass we say is 20, but actually it's a little later for men, a little earlier for women. And of course there's this big individual variation. You know, that really short guy who kept growing and suddenly he was just as tall as everybody else by the time he got to 30. That happens. So the peak bone mass is a combination of keeping on growing and growing more bone, but also increasing the density of that bone, because the bone cells actually produce an organic material called osteoid, because they're cells, they can't produce a mineral. So they produce the bone tissue, and then that tissue has to be mineralized. So all new bone tissue, it takes a while for that new bone tissue to become actual hard mineralized tissue. It's one of the reasons why if you do an intervention, you must wait at least 6 months, and we prefer 12 to test, because DEXA tests mineral. It can't see the osteoid. That's why we sort of, these studies take so long. It's not like muscle doing a 12-week intervention. You can't measure a change.
What about, do you use trabecular bone scores as well, like architecture of the bone rather than just the actual density of it?
Well, I would love to have used that in my studies. At the time that we did our 3 clinical trials on the high-RIP program, we didn't have trabecular bone score. I only just last year got a DEXA with that software. It is relative. It's not really new, but it's certainly new-ish. And if I could get some funding to run a study looking at that, I absolutely would. So the trabecular bone score gives us more indication of how thick the trabeculae, or the little struts and beams inside the bone, are.
Just for anyone that doesn't know, the trabecular is more so, the more porous part of the bone on the inside of the bone, and then you've got the cortical bone, which is a very hard sort of bone on the outside. Is that correct?
That's right. If you think, I'm sure you would have seen a long chicken bone, and at the end it has the sort of bulbous end. If you ever see inside that, there's this very spongy looking bone material. That's trabecular bone, and we have it inside the ends of all our long bones, inside our vertebrae, in various places. And that tissue, because it has a very large surface area, it's the fastest to remodel, because the bone cells can attach to a large surface area. It's much faster than cortical bone. So it's the one that tends to be affected by osteoporosis the most, because that's where a lot of resorption happens. And it's also the place where you can get a response quite quickly as well, for the same reason.
I like that. And what did bone turnover markers, so the collagen P1NP and CTX, do you want to use them at all? Or is that mostly just for, because I just see them if people are prescribed either anti-resorptive or anabolic medications.
Yeah.
But is that something that the studies are starting to use more in terms of exercise interventions as well?
The well-funded studies, yes. Unfortunately, it is so hard to get funding. First for exercise trials, and secondly for bone trials. So combine the two, and it's almost impossible, which is why those 3 trials I just mentioned were PhD projects and essentially unfunded. So we ran them on the smell of an oily rag, which meant we couldn't afford the assays. But I did just finish a large-scale funded trial on vibration, actually, and because we had some money, we did do assays for vitamin D and for P1NP and CTX, so bone formation and bone resorption markers. Didn't see anything, but that was a complex trial. We don't do it with our clients at the clinic because we're not doctors. We don't draw blood. We don't spin it down and analyze it. And also, people don't like having blood drawn, and so we do a lot of testing. And it would be sort of, if it's one more thing, that it would be a deterrent for them.
Yeah, that makes complete sense.
Can you explain? Because I think even from my practice perspective as well, and training and recommendations, a lot of what I did over the years is refer back to your Lift More study and Lift More M, and you've also done the MEDEX osteoporosis program as well. Could you just explain to our listeners just how they started, what you actually ended up finding, and the recommendations, because they ended up finding probably the most effective ways of actually improving bone density.
That's right. It was, you have these moments in your life that you remember when they're sort of light bulb moments. And I was at a conference in the US where I spent a lot of time talking to my bonehead peers who are also exercise physiologists. And we were all just at a point where we were looking around each other. Well, is this the best we can do? Exercise seems like it's either not helping at all, or it's just preventing bone loss.
Yep.
And is this really the best we can do? You can see in animal trials we can improve bone. Why can't we do it in people? So because I had this background in animal research, I knew that the kind of loads that grew bone were high magnitude strain inducing loads, things that bent the bone a lot. And I thought, why aren't we doing that? Well, the reason we're not doing that is because it's terrifying to load somebody with with a frail bone heavy. And that's why nobody was doing it, including me, except in kids. So it came to a point when we just said, you know what? We can't say it doesn't work if we don't test it. And we're going to test it.
Cool.
So we had 3 physios on the project. Belinda Cowboy, just, I'm going to do this. And we had to get it through ethics. And
how did that go?
Well, they were actually pretty good because they could see that we had everything. If you control the risk to the best of your ability, at Griffith, our human ethics board is really very good.
Okay.
They're supportive of research. And so we just designed it so there would be a gradual increase in loading. People would be started at the point that they were that matched their capacity. We would teach them the movements very carefully so their technique was great. We'd load them gradually. And then we loaded them, and we really loaded them. And we added impact, which is another thing that everyone said, don't ever jolt your bones if you have osteoporosis. Well, we jolted them because that's what bone likes if it's going to adapt. And at the end of this 8 months of intervention, here we had this beautiful increase, particularly at the spine. Again, trabecular bone, it's responding to this signal and getting stronger. So at the hip, it was really interesting. When we did our DEXA scans, we weren't getting much of a change in BMD. It was just like all the other exercise studies, not much change detected. But luckily we had this cool 3D hip software that we could reanalyze our DEXA images. And it showed us that even though bone density wasn't necessarily increasing, the shape of the bone was changing and the cortex was getting thicker. And of course, if you think a pipe with a very thin cortex, easy to break, thick walled pipe, not so easy. And the thickest part that was getting most dense was the femoral neck, and the lateral part of the femoral, which is exactly where the fractures happen. So this was a little dance on the spot moment.
That's cool.
We did it, and that was with postmenopausal women over 60. And with low bone mass. So then we ran the Lift More for Men trial, which was with men. That one was, we can talk about that if you'd like, that incorporated, it was a very similar design, except at the same time I was given a big machine called a biodensity, which became OsteoStrong. So you may have heard of OsteoStrong. It's a company that sells machines to do an isometric load on bone. And at the time I thought, that doesn't make sense because bone likes dynamic loading. You can't just push on bone and expect it to change. In fact, if you do that, you lose bone, and the animal study showed that quite clearly.
Oh.
So, and they did one maximal exercise on each of 4 exercises on this big machine called the biodensity. So I thought, well, it's actually quite similar in arrangement to the high intensity resistance and impact training we were doing. So we had it as a parallel trial, a parallel group in our Lift More for Men groups. This is the men's study. It didn't work, and yet the high rep did. Our program did, still worked in men. So that was a nice little side outcome from the Lift More for Men study, because it's the only high quality study that's ever tested OsteoStrong, and it does debunk the claims that they make. They have no good evidence. Then we did the medics open. We actually opened the bone clinic after that because it was pretty obvious this thing was working, and people were just clamoring for it there, and there was no way for me to. I wasn't just handing the program over because if it's not supervised by someone who knows what they're doing, it's not safe, particularly for very frail people. So we opened the clinic and started that process. We can talk about that too if you want. But while I was there, another student from Switzerland contacted me, and she wanted to do a study. And the next obvious step was to see if the combination of bone meds and our program.
Which bone meds did they?
So we decided to only include anti-resorbatives because at the time the only, anabolic was PTH, and it was really expensive and not many people were on it. So we, just to keep things simple, we stuck with just anti-resorbatives, so bisphosphonates and Prolia. So
just for people listening, so what is an anti-resorptive?
So you have 2 classes of medications you mainly use. One is to stop bone breakdown, and one is to actually build bone. But the one to build bone has a lot of regulation. They're very expensive, so more difficult to get. So the much easier and much more accessible medications are the anti-resorptive to prevent further loss. But if you've had, a good example, if to meet the PBS criteria to get these medications on PBS, you have to have 2 or more fractures, you have to have failed all the initial medications that just prevent bone loss before you can start medications that build bone.
Interesting.
Which is interesting that you have to have multiple fractures. But it's a cost analysis. But I do have some people who have already had fractures, already osteoporotic, who have resources, and you have to weigh, okay, for this person, is it best for them to start Prolia and wait for more fractures, or to start an anti-resorptive and wait for fractures, or is it in their best interest to start something that builds bone in addition to exercise, nutrition, making sure they're sleeping well, etc. So it's just a matter of personalising every treatment.
Yeah, meds has actually changed quite a bit in the last, say, 4 years with the onset of Evenity, the romosozumab, which is actually anti-resorptive and bone building. So it's a bit of a wonder drug, but there are some caveats, and you should only really be on it for 18 months. So it's not the this is what I can use for the rest of my life.
You'd probably see this as well, but I find that a lot of hospital medicine is like you get started on Prolia because then they're discharged to their GP. Despite the best intentions, then everything else falls by the wayside, the exercise, the nutrition, and then it's just a Prolia rather than actually doing other things to actually help build bones as well. So that's where I find that from a health system, we need to do more to actually provide a more comprehensive evaluation and assessment and ongoing management of people with osteoporosis.
That's exactly right. And it also worries me if you say that the hospitals are putting everyone on Prolia, because that's okay if they're quite old, but really the first line should be a bisphosphonate because, as we've learned, if you come off Prolia, the loss is so rapid and dramatic, and the risk of fracture is actually increased 6 months after you stop. So, the recommendations nowadays is Prolia not first
even
option.
if you miss a month as well, it goes quite quickly. You have to be very specific on the dates as well.
Yeah, it's quite frightening, and it really does. You're pretty much on it for life, which is why they say start it late. or you have to, if you are going to come off, you have to go on something else. And
Yep.
and there's a definite order of how of the benefit of these meds, whether you go on an anabolic first or an anti-resorptive. And I think the conventional thinking now is coming around to the fact that anabolic first, anti-resorptive later is better than trying an anabolic if an anti-resorptive fails.
Yeah.
Now they're starting to get those kind of data. So hopefully
That's going to be
rules,
game-changing.
the
Absolutely.
rules will change.
And
yeah.
it's just going to be so much easier. You had a fracture, let's build bone, and it's just going to be, I think the uptake is going to be far more easier for patients as well to be like, I'll start that, do anything to build bone because I don't want to have another fracture.
Yeah. And then, of course, really what they should be saying in the hospitals, here's your nearest neuro provider. So go and do some exercise because that is the absolute number
exactly
one
right.
best thing
That's
you can
exactly right.
possibly do.
Yeah,
Yeah,
I agree.
What was the outcomes of medications and exercise or versus exercise?
So because we're not doctors and we can't prescribe meds, this was a study of it was what we would sort of call a convenience sample. We recruited anybody with low bone mass with a T-score of -1 or worse, and then we stratified our randomization according to whether they were on or off meds, and they had to have been on meds for 12 months and was stable, and they had to plan to stay on meds for the next 12 months when we through for the program, and equally the people who were not on meds, they had to plan to not be going on them. Not that we could stop them if they changed their mind, of course they were able to do that. So the answer to your question, if you looked at it ended up being 4 groups. So we had a control group, and the control group was an active control, because these days in an exercise trial, because we know that exercise is good, you can't just say don't do anything. So actually what we did in our control group was a Pilates program. It's called Buff Bones. It's Pilates. We know Pilates doesn't work, and sure enough, it didn't work. So people
Is that
in
reformer or mat, like floor?
it was mat Pilates, but they have added in some stomping and stuff to try and make it. It is not evidence based. Just put it that way. So in our 2 groups, we either had control, Buff Bones, or a neuro, the high intensity resistance to impact training. And in those 2 groups, they were on or off meds. So the group that was doing Pilates and they were off meds, they lost 1.2% of BMD at the spine.
Which is actually quite considerable.
Which is quite considerable. And that was the mean. So that was showing that the Buff Bones didn't work. The ones who were on medication and doing Buff Bones gained, and I wish I could remember exactly how much it was, but I think it was sort of in the order of about 2%. The people who were doing Oniro, our exercise program, no medication, also gained about 2%. And then the ones who were doing Oniro and also on meds also gained about 2%. So it didn't look like there was an interaction. At the hip, there possibly was a little bit more effect, because remember I said that at the hip it's not increasing BMD, the exercise, it's changing shape. It looks like if you have meds and exercise, then maybe you're increasing BMD and changing shape. So since that trial, and we can talk about this if you'd like later, the results from the Bone Clinic is showing some other really interesting effects, including the exercise and meds.
Oh, it's awesome just to be able to differentiate between those, because, usually one thing might just be recommended, but if you can either go back to just doing exercise, you might not even have to go through the rigmarole of all the medications of going on for life, coming off it, then having the risk of potentially losing a lot more bone as well. I run a real risk of doctors getting cranky at me for suggesting that exercise is as good as meds on the basis of the MedXOP trial, because the number of people who were actually on the numbers were quite small. So but now that I have the data from the clinic, I have strengthened those data, and I feel very, very strongly, because we see such a consistent positive effect from Oniro, that I'm pretty confident these days, and
I guess I'm emboldened to say that some of the downsides of the drugs and the lack of efficacy, some of the side effects, the patients just don't want to be on them. You have to be thinking that if there is something else that's effective, you shouldn't be ruling it
Yeah,
out.
exactly right. Do that first. Yeah.
So how does bone actually become denser, stronger through loading or through jumping? You said before the isometric loading doesn't actually make much change. Pilates doesn't really make much change either. How is it that the contraction, push and pull of the loading, is it only mechanical or is it hormonal? Is there other physiological mechanisms that are happening that are causing bone to increase in density, or what's happening?
I think predominantly it's physics. It's the mechanics of it, which makes sense because Wolff's law basically says our bones will adapt to the forces that we put on them to prevent fractures from that sort of loading. So the bones can perceive load by virtue of their bending slightly or deforming. If it's a block, they can sense that deformation because actually bone tissue is full of holes and the bone cells live in those holes and they're all connected by canals and the whole thing is bathed in fluid. And when you compress or deform a bone, that fluid is squeezed through those canals from one side to the other, and they shear across the bone's cell surface, which is what stimulates them to start doing something. So it's a fluid flow mechanism that is the transduction mechanism of the load to the cell and causes them to adapt. So there's a whole bunch of biochemistry that goes on, and I'm not a biochemist, so I try to stay in my lane, but that's the basic long and short of it. And so a long bone will bend slightly. You'll notice that bones are not straight. They're actually designed to be slightly curved because that allows for bending. So it's a very, like I said at the start, it's just a beautiful tissue that is so well adapted for our mechanical environment.
That's the thing, we have no appreciation for it because we don't see it.
Yeah, that's exactly
We don't actually see what's happening. You said you did animal studies too before, so how much loading were you actually putting into the bones for them, or how were you loading the bones in animals?
Well, we loaded it with a device called an instron. It was slightly technical. We cut the ends off the bone. The animals were anaesthetised, obviously. Cut the ends off the bones, put caps on the bones, at the ends of the long bones, and put pins through the whole lot. And then you can load the ends of the pins to either load the bone axially along the long axis, or you can load one side of the pins and you can bend the bone. So that was how we could then put strain gauges on the bone and see what strain was happening. And we could also put little electrodes on the bone and pick up that fluid flow, which is essentially what my PhD was. So you can... Bone has a fracture threshold, and it's the same for every animal, from mice to elephants. The fact that elephant bones are big means that just because they're heavy doesn't mean their bones bend more. Their bones are bigger to withstand that. Mice are little and their bones are little. So when they bend to roughly the same amount of strain, and the cells see the same sort of signal. So there is a bit of variation, but there's been a lot of... Ribben and Lanyon did this work years ago and tested all these animals, and the strain is the same.
Wow. Evolutionary preserved, I guess.
That's right. Yeah, it's cool.
That's very cool.
It is, it's actually, again, it gets so interesting when you hear the other aspects of it from how you actually did it. And speaking of studies, you've got another study coming up, the stop fracture.
Yeah, so we are actually in the middle of the stop fracture study, and we're just coming into our last year. Now, because we have been delivering Oniro at the clinic for years, for 10 years now, and I think one of your questions was alluding to the fact that, how do we make a change? We need to get the word out, and we need to educate doctors, and they need to know that this actually exists. But also, we need some equity in access to treatment. So with drugs on the PBS, everybody has access to that if they meet certain qualifications, and it's reimbursed. With exercise, that doesn't happen, which means only people who can afford it can do it, which really doesn't sit well with me. So the purpose of the Stop Fracture study is to raise awareness of O'Neuro with doctors, to increase referring so that we could get this really large sample and try and show that O'Neuro is reducing hip fractures. If it does, then we can go to the government and say, excuse me, here is something that is working like meds. There is no reason why this shouldn't be on the reimbursement schedule as well. So everybody has access to it, not just the wealthy. And so the Stop Fracture study is an implementation trial. It's not a study. It's not a trial. We're not testing whether it works. We know it works. It's now we're trying to get evidence to convince the government to reimburse for effective exercise
Showing
therapy.
scalability and repeatability, I guess, in multiple environments.
Yeah.
Is that pretty much? That's very cool.
Just to finish off, what are your long-term goals? What would you like to see by the end of your career?
So I think sort of the manifestation of the Stop Fracture study, I would love to see effective exercise available to everybody and that all doctors know about it. So it is the absolute number one first line recommendation for somebody with low bone mass right through to osteoporosis, so we can stop osteoporotic fractures. People can retain their quality of life and their independence throughout life. It is better from a personal level, but imagine the savings to the health budget and taxpayers. So it's a win-win. I feel like I'm about 7/8 of the way there, but the last step is a huge one, and I'm hoping that the government comes on board.
I think I saw that it was about $3.5 billion in fractures it cost Australia in 2023. Just alone.
It's that's it's horribly expensive.
Or $40,000 for a hip surgery. So,
Plus the rehab afterwards.
Plus that.
And then likely nursing home. And
exactly. All the costs of maybe not even going back home. You got to get your family looking after you. Yeah, it's an awful way to end. We haven't touched on the O'Neuro program this week, but we will be next week. And so that's where we really wanted to wrap it up there today for our main episode of the Bone Health. So what we'll go into next is going to be how do we actually prevent this and what are the most actionable steps that we can implement for, people in their 20s, 30s, 50s, 60s, 70s, post-menopausal. And so that'll be our rapid fire that we're going to work on, spending about the next 15 minutes as well. Thank you.
Pleasure.